involvement, that is the inflammation is there. This is scleritis. So there is no serologic test that is diagnostic, and mild normocytic normochromic anemia and leukocytosis may be there. Rheumatoid factor, ANA and anti-CCP antibodies are usually negative, and synovial fluid analysis show 20,000 to 50,000 of count. So the clinical suspicion must be very high. These throat swab cultures and everything should be done to rule out the persistent infection. So radiographic manifestation, usually there is periostitis, and the spinal finding may be sacroiliitis and syndesmophytes. This is the periosteal reaction. The viral arthritis, I go very rapidly through it because I'm getting short of time. So with viral infection, we do have hepatitis C, hepatitis B. Patients do come with us, those who have viral infection and present with arthralgias and arthritis. So in these patients, we look for these. In the patient who have hepatitis C, we know that they may have these antibodies positive, so we must be very careful that they are not suffering from any coexisting disease. And we manage the arthritis with NSAID, HCQ and low dose prednisone only. Antiviral therapy can be given, but it doesn't show any significant improvement. And the patient who have both disease coexisting, in mild cases we can give hydroxychloroquine and low dose prednisolone, and methotrexate and leflunomide should be used with extreme caution. In hepatitis C, B virus, we come across with arthralgia in the acute stage, not in the chronic stage. So I think I have to wind up here. I'll talk a bit about the conclusion is that most of the patient with joint or muscle pain have limited range of motion. They have primary disease like RA or OA, but however a few have a systemic infection that is affecting joint, muscle or both, and the chief complaint can be joint pain. So a vigilant physician must be aware of these conditions to make an appropriate diagnosis of the treatment. Thank you.
Thank you, Dr. Tahira. Now I will again invite Dr. David D. Cruz to give his state-of-art lecture on modern management of SLE.
Thank you very much again. I realize we're running short of time, but so my next topic is modern management of lupus. I think it's worth starting with disclosures, because I think it's quite important in this day and age now. I need to tell you that I am associated with various funding companies, pharmaceutical companies, Spriva, HGS, Roche, who are sponsoring me for this trip, Genentech, BMS, and Teva. I'm actually quite proud to have some disclosures, in fact. 10 years ago, I had no disclosures, and the reason was the industry was not interested in lupus, which was a tragedy. So it is a tremendous tribute to industry who've taken a big interest in lupus, and they're really working hard to develop new therapies for our lupus patients. So we know that lupus is a multi-system disease with many different manifestations, very challenging manifestations. There are no diagnostic criteria. It's important to recognize that these ACR classification criteria are just that, they're classification criteria, and for inclusion in clinical trials you need 4 or more of these 11 criteria. And I think it's an important message that I keep saying, especially to the registrars and the trainees who tend to misuse these classification criteria as diagnostic criteria. These are highly specific criteria. They're not sensitive. In other words, if you use these criteria to make a diagnosis of lupus, you probably miss about half the patients. So I think it's an important point that's worth stressing to the trainees in the audience. That's enough about my preaching. So what about the treatment of lupus? I think we all focus as clinicians on disease activity. But I think in order to capture the totality